least PA and lateral chest x-ray, get the most important views out of the way and talk about what to look for in your image before you repeat it. An awful lot of what we're going to be talking about is, ideal images, what an ideal image looks like. Just because something's not positioned perfectly does not necessarily mean it's a repeat, which you should know by now. Some things are things that if you were to go back and repeat the image, it would kind of be not just counterproductive, but it would be bordering on medically unethical to reshoot. For example, if you shot and you failed to collimate, you didn't collimate enough off, so you overexposed the patient, it'd be ludicrous to go back and reshoot that a second time and not only overexpose the patient the first time, but also repeat the exposure and double the dose shooting it a second time. So in that way, you would be not only double dosing the patient, but over double dosing the patient. So some of the things we're going to talk about are things to learn from and then not repeat on future exam types. So not all the images are bad. Even the bad images, not all of them, depending on patient condition and what the problem was with the image, not all images would I repeat. As a matter of fact, most of them I would not, depending again on what the patient's condition is. So we've got some bad images in here that we'll look at and talk about whether or not we would repeat those, whether or not we should repeat those, and how to correct them, the things that we did wrong. So we're not going to spend just a tremendous amount of time talking about positioning. You should have that by now. We'll talk about the things that you kind of need to keep in mind all the way through the registry, the positioning points and things like that. That might have just kind of slipped away, right? Because it's been a year since we've done this, so some of those positioning points might have slipped away. So we'll kind of touch and brush over the general positioning, but for the most part, we're going to focus on image correction. So just real quickly, PA chest positioning, we're going to talk about mispositioning both PA and AP at the same time, because what we're going to look at are the same things. The rotation is going to be just a little bit different, but we're looking at the same thing essentially. So top of the collimated field, top of the image receptor, I'd specify collimated field on this because you might not be using the entire image receptor. So top of the collimated field is more precise, but top of the image receptor if you're using the entire image receptor. So 1.5 inches above the relaxed shoulders, and I point out the relaxed shoulders because some of your patients, and the demographic here is usually small, thin, little old men walk around with their shoulders arched up, right? Some of you have seen these, the patients walk around with their, shoulders up. So make sure that you get their shoulders relaxed, and then 1.5 inches above the outer portion of the shoulder. Don't forget to rotate your shoulders forward. Make sure you collimate down too, and that's probably not necessarily in the images that we're going to look at, but in the images I see online and the images I get sent to me, probably the most common thing is under collimation, just almost a complete lack of collimation. So your collimation should be to your skin line, or maybe 1 inch past the skin line. All right, so make sure you collimate, rotate the shoulders forward, get the scapula out of the way. Second inspiration, just to make sure you get that deep inspiration, centered at T7. All of your chest x-rays, with the exception of the apical lordotic, your centering is going to be at T7. Why? Well, that's pretty much right in the middle. Well, we've got 12, wouldn't 6, in between 6 and 7 be in the middle? Yeah, number-wise, but you got to remember that your vertebrae at the top of your thoracic spine are smaller than the vertebrae at the bottom of the thoracic spine. So T7 really puts it pretty much right dead square in the middle. So where is T7? Inferior border of the scapula. You can take a look. If the patient's got a gown on, you can kind of, open it up a little bit and kind of get an idea as to where that is. So artifacts are probably the second most common thing that I see behind collimation, artifacts not removed, and removed in a way that doesn't really remove them. What I mean by that are things like your telemetry leads. You know, if the patient comes down and they've got a heart monitor on, it would seem common sense would say you know, you've got these leads all over the patient's chest, you take the heart monitor and you set it up on top of the wall bucky, right? But what happens with that is that the leads, especially on the upper end of the patient's chest, you know, the top leads, those wires just kind of swirl around, and you actually wind up with more wires in the image than if you were to just take it out. You know, a lot of cases they're wearing that sling, take it out of the sling and just put it down, you know, let it hang. If it pulls a lead, it's going to be pretty obvious. Nobody's going to come in and try to do CPR on your patient because the lead got popped off, but you know, you can correct that whenever you put it back in the sling. So bras, necklaces, even sports bras, really, you know, the amount of elastic and the thickness of the material, they can cast an artifact. So, you know, even if your patient says, well, sometimes your patient will say, well, it's just sports bra, when it truly is not. And you can tell that because you've got the hooks and everything. But also some of the thick material may cast an artifact as well. Necklaces, tubes, if the patient has a NG tube, that's got to come out of the way. The wires we talked about, the buttons and snaps are kind of difficult to get rid of in a hospital gown. If a patient comes to you with their gown on, you got a little old lady that comes into the ER and she's got her nightgown from home on, you need to check it real good for things like safety pins. They almost always have a safety pin in them. You can ask them if they have a safety pin, they'll say no, you shoot your image, big old safety pin, almost every time. In my experience, almost every time. So get all the artifacts out of the way. Of course, you know the considerations for hypersthenic. Your collimated field should most likely be more broad and shorter. That's one of the positioning mistakes I see, is that you get a hypersthenic patient and you go back to this slide and you put the top of the image receptor 1.5 inches above the relaxed shoulders. You open your collimators, you know, crosswise because it's hypersthenic patient, but you also are, you know, top of the image receptor is top of the shoulder, so you're going to use the entire image receptor. So you've got a 16 by 16 or 17 by 17 collimated field, and you get half of the abdomen. You know that the lungs on a hypersthenic patient are pretty short, right? So you don't need that entire length on a hypersthenic patient. As opposed to a hyposthenic patient, if you have somebody who's got a runner's build or swimmer's build or something like that, you're probably going to need that entire image receptor to get them on the, you know, the whole lung on the image receptor. Back when we used to use screens and films, our largest image receptor was 14 by 17, and the only person that you might not be able to get onto the image receptor in either dimension, crosswise or lengthwise, was going to be your hyposthenic patients. They just got lungs that inflate forever. So you put it in crosswise, they're going to be too long for it. You put it in lengthwise, they're going to be too broad for it. They just inflate forever. So those patients, you might need to use the entire image receptor. Your hypersthenic patients, you do not. Your asthenic or sthenic patients, you probably don't either. So proper placement of the image receptor is important so that you get your collimated field right. Shoulders rotated, we talked about. Second inspiration, center C7, we talked about all that. So that's what it should look like. Remember that, you know, the things, the evaluation criteria that we talked about in Merrill's, you should see how many ribs? You should see 10. Yeah, not all your patients are going to have that kind of inspiration though. Again, your hypersthenic patients, you're probably not going to get 10 posterior ribs in the lung field. So your first two are going to be almost directly on top of each other. So you've got 1, 2, then you've got 3 right up under the clavicle, 4, 5, 6, 7, 8, 9, and you've got a portion of 10 on the right-hand side, most of it on the left-hand side. So that's what we're looking at are the 10 posterior ribs. You can always tell posterior ribs because posterior ribs look like they come all the way to the vertebra. You know why they look like they come all the way to the vertebra? Any guesses? Because they do. Okay. All right. So the anterior ribs, they stop right out here. Remember that you've got true ribs, you've got false ribs, and you've got floating ribs. So the true ribs are going to attach directly to the sternum. Then you've got the false ribs that attach to costal cartilage that then again attaches to the sternum. So direct cartilaginous attachment to the sternum for the true ribs. You've got costal cartilage that attaches to costal cartilage for the false ribs, and the floating ribs have no attachment at all. So what we're going to look for in our chest x-ray is what we want to see is from costophrenic angles down here all the way up to the apex of the lungs. We want to make sure that we get both sides, so our collimated field should be open enough that we see both sides and we see no rotation. So what do we use to determine rotation? Clavicles, the ends of the clavicles and where they appear to hit the spine. And you know why I say they appear to hit the spine is because they do not. They're way up front, anterior, and that's what we're going to use to determine rotation. So the things that you can do to to make sure you get the scapula out of the way, sometimes you can have the patient, if they're a little bit unstable, you can have them reach around the wall bucky. If you have a patient who can follow instructions, you see that they've got this patient's hands on the backs of their, kind of on their hips, and that's a very good way to make sure you get the shoulders out of the way. Put the hands on the hips and rotate the shoulders forward. If you're shooting a portable chest x-ray, some of these things are, we just have a tendency to overlook. So let's say you're shooting an AP either in the department or portable, and you've got the patient on a stretcher or in a bed, and most of the time you walk into the room and how's the patient situated in the bed?
Leaning back.
They're leaning back, right? They're comfortable. They might be hiked up on a hip, something like that, right? So they're comfortable. They're watching TV. They're doing their thing, and you're going to disturb all that, and you need them to set up straight so that you can get a good chest x-ray. If you elevate the bed and the hips aren't all the way back in the bed, then you're going to get a slouched chest x-ray. And what's going to happen there is that the bed comes up, the chest bends forward, the hips aren't where they need to be, so it's going to further accentuate that slouch, and as a result the anterior chest field is going to compress. You're just not going to get a good chest x-ray. So draw sheet is your friend, especially if you're working alone. Draw sheet is your friend. So what you want to do is you want to pull the patient up into the bed, and certainly they can push while you get your hand up under their arm and pull them up into the bed. Or if you're working with somebody, just grab the draw sheet, one on either side, and pull them up into the bed. If they're still facing in one direction or another, whichever side they're facing toward, you grab that draw sheet and you pull it, and it's going to shift their hips, and they'll just snap right into place. So now they're straight up, right? So the things that you want to make sure that you don't do when you're doing a portable chest x-ray is sit them all the way up before you try to put the image receptor behind the patient. A reason for that is most of the time your patients, when you're doing a portable chest x-ray, they're real healthy, right?
Oh, yeah.
No, that's why you're doing a portable chest x-ray. So what you want to do, let me finish that thought. So you got this patient sitting there, the legs straight out in front of them, and you try to sit them up almost to a 90-degree angle, and then you want to pull them forward and put the image receptor behind them. So they're already uncomfortable, and they're probably with their flexibility, they're probably as bent as they can possibly go. So you start to pull them forward and their back stays in contact with the bed. Now the thing that you're gonna have to do is either lower them down so you get that separation between the bed and the patient's body, slide that image receptor down, or you're just gonna have to jam it down, behind the patient. Now you've barked the patient's spine, you've taken some skin off the patient's spine and you've got an incident report. Now you're in trouble, right? So don't do that. So set the bed up a little bit, pull the patient forward, put the image receptor behind the patient, set the bed the rest of the way up, adjust the image receptor, and then get ready to make your exposure. I've worked in hospitals where it's almost routine on portable chest x-rays to shoot 40 inches. Really don't recommend that. You're gonna have more flexibility in your positioning if you shoot at the foot of the bed, instead of dragging the tube across, right across the patient's knees. I don't mean truly right across them, but just above the patient's knees. You can just drive the portable to the end of the bed and kick the x-ray tube up without really moving it aside from just straight up and down, right? So what you want to do is angle to the patient's sternum for your portables. With a PA, you notice she's got her shoulders forward. What else besides removing the shadow of the lung field does that accomplish whenever you rotate the shoulders forward? It rolls the scapula out, but what else does it do? So I'm standing straight up like this.
It flattens your sternum against
Bingo! Flattens the sternum. I'm standing straight up like this and forgetting that I've got a gut. My sternum's kind of like that, right? If I do this, what happens to my sternum? Straight up and down, right? So while the sternum kind of, becomes more vertical, the clavicles also dip just a little bit. So would it not stand to reason that if you're shooting a portable chest x-ray or any kind of AP chest x-ray, if our central ray is going to be perpendicular to her sternum, then if I'm doing an AP, would it not make sense to put the central ray perpendicular to my sternum if I want my x-ray to look the same whether it's AP or PA? Kind of common sense, right? So the one thing that we have a tendency to overlook whenever we're doing a portable chest x-ray is the position of the patient's hands and whether or not we can get those scapula out of the way. And you can. It's a little bit more awkward, one thing that you can do, and one thing I recommend that you absolutely do, is make sure that the patient's not bracing themselves on their hands. First off, if they're doing that, they're elevating their shoulders, and it makes it more difficult to tell where to put the top of the image receptor, right? So get the hands out of the way, and if you withdraw the hands, abduct the arms out and away, it's going to do a portion of that. You can certainly have the patient rotate their shoulders if you want to. Never seen it happen. Never done it myself. But you may run into a registry question that asks you about specifically rotating the patient's shoulders for an AP chest x-ray. Should you? Well, according to the textbook, yeah. Are you gonna do it? Maybe not. But if you get your arms out, get the patient's arms out of the way, you should clear at least a portion of the lung field from the scapula. So that's everything that you want to see. Labeled. All right, so we just talked about that, so I'm not going to go back through that. So our evaluation, we talked about that. We want to get from the apex to the costophrenic angles. We want to make sure we have both sides visible. We don't want any kind of rotation. Understanding that if you have a patient who has scoliosis, you're not truly going to be able to get rid of the rotation. So scoliosis is not just a lateral bending, but you're going to have some degree of rotation of those vertebrae as well. Okay, so on your AP or PA, you're going to have some degree of rotation. If you've got no rotation at the clavicles, you're still going to see differences in the lung field, in part because of that curvature, but also in part because of maybe some slight rotation of the vertebrae as well. On your lateral, I'm gonna go ahead and drop this. Your lateral, you're always going to have rotation on your lateral chest x-ray for a patient with scoliosis. There's nothing you can do about it. So the first thing that you need to look at whenever your lateral comes up is look back at your AP and look for presence of scoliosis. If scoliosis is present, just don't worry about your lateral being rotated. You can't get around it. You can shoot it all day long and you're gonna have a rotated lateral. So watch for scoliosis. We want to make sure we have penetration and make sure our contrast and brightness is good. Really, the only thing that's going to mess that up again is going to be if you select like a rib algorithm for a chest x-ray. And you see all that stuff. So common things to look for. All right, so I already talked about elevation of shoulders. What's going to happen with elevation of shoulders is that the medial end of the clavicles don't move, but the lateral ends elevate. So what you're going to see is a very steep V shape in the clavicles. And so the clavicles are going to cover the apex of the lungs. Is that a huge deal? In the scope of things, probably not. With the other things to consider, it's probably one of the least important things to really stress about. Again, if you have a patient whose shoulders just look flat, then they're holding their shoulders up and try to talk them into relaxing their shoulders. So you got elevation of the shoulders giving you that V shape. Kyphosis versus lordosis. All right, so you can have a patient who's kyphotic because of multiple compression fractures in the spine, and that's going to give them a natural kyphosis. Okay, so where we had rotation of the shoulders, putting the sternum vertical, it can exaggerate that, and it becomes much more of a problem on your APs than what it does on the PAs, and I'll get there in a second. But look for, if a patient kind of has a little bit of a bow in their back, especially your older patients who are prone to compression fractures in the spine, just look for that. All right, so on your portable chest x-rays, your AP chest x-rays, still try to angle perpendicular to the sternum. Again, I'll get to that here in a second. Also, though, what we might get with kyphosis is not truly kyphosis. Again, if you got a patient that's got a belly and you tell them that you want them to put their chest up against, I want you to put your chest all the way up against this board, and they've really got a great big belly, they'll do that, but the belly's going to hit first, and that's going to cause them to lean forward into it. And what that's going to do is it's going to take the clavicles and it's going to lower the clavicles in the chest. Okay, so it may give us also a little bit of a V shape, but it's going to take the clavicles and it's going to put it further down in the chest. Where you want to see your clavicles, and bring this back up, where you want to see your clavicles is right around the third or fourth rib. So we've got 1, 2, we've got 3, 4. This is the aortic arch, okay? So a lot of cases your aortic arch is more prominent than that. You can see it a whole lot better. The closer the clavicles get to your aortic arch, if they're below T4 or the fourth rib, then you're kyphotic. Okay, so why are they kyphotic? Well, if the patient's kyphotic, then they're going to be kyphotic, but also if the patient is leaning towards the image receptor again, if they got a great big beer belly and they're leaning towards the image receptor, that's what you're going to see is the clavicles down at T4, fourth rib or below. So if you have a patient then who is kyphotic and you're doing a portable chest x-ray on them, it's usually postmenopausal women that get the compression fractures. My mom, she had them, and she had a little hump on her back. But you set them straight up, they're already, leaning forward. They can't straighten up. They've got compression fractures. Their back is broken. So what you may have to do is, we have a tendency to get into this idea of the patient sitting straight up, angle 5 degrees caught at. If the patient's laying flat on their back, angle 5 degrees caught at. That doesn't really get us where we need to be, because if we've got this kyphotic patient,
then how's my sternum right now?
Straight.
It's pretty much straight up and down. If I angle 5 degrees caudad, what am I gonna show? It's gonna take the clavicles and it's gonna push them, because they're further away from the image receptor, it's gonna push them further down into the thoracic cavity. So they're gonna get closer to the aortic arch, okay? So I've had patients who were so kyphotic, and when I set them up, you know, their sternum was at an angle more like, instead of straight up and down, more like this. I've actually had to angle upward into their chest, put the x-ray tube at the foot of the bed, drop it below the foot of the bed, and angle upward into the chest to get a decent looking chest x-ray. Okay? So that's the other thing you're gonna look for, is kyphosis. If they're kyphotic, if the clavicles are down further in the chest than they need to be, then one of those things happened. Your angulation on your portable chest x-ray wasn't right on your AP, or you know, the patient was leaning towards the image receptor, or the patient truly was kyphotic. If you're doing a PA chest x-ray on a patient who's that kyphotic, you might not be able to avoid it. You may have to angle cephalic on a PA chest x-ray. All right. So lordosis, though, is something we're a lot more familiar with. So lordosis is any kind of positioning of the clavicles that is above that point. Right, so if the clavicles are around T2, second rib, then we've got some sort of lordosis that's covering the apex of the lungs. So if it's around T2, second rib, probably not going to repeat that, but just remember next time you come in to angle to the patient's sternum. Most of the time that is going to be on your portable chest x-rays where you didn't get the bed upright, or you didn't angle perpendicular to the sternum. The patient was still slouching a little bit. Maybe right before you made your exposure, the patient decided that they were uncomfortable and kicked their hips out. Anybody had that happen on a portable chest x-ray? If not, you will. On a PA chest x-ray, if the patient turns their head a little bit, you're gonna get a little bit of rotation. Scoliosis, we already talked about. Poor inspiration. Make sure you watch your patient, take in a big deep breath, blow it all out, and watch them for that second inspiration. Take in another big deep breath and hold it, and make sure that they hold it, right? Because sometimes your patients just, either they don't understand the instructions, or, you know, they, I don't know, they get tired of holding breath. Maybe they're that short of breath. So leaning occurs most of the time whenever we're doing portables again, and it's not really something to get all that upset about, providing that you don't have any of this other stuff going on. So let's say you straighten the patient up, they're still uncomfortable, they lean off to one side a little bit. What that might do is, if they're leaning enough, it might compress the lung on the side that they're leaning towards, if that makes sense. So you don't want that, but probably the second least thing to really get in a twist about behind the, you know, elevation of the shoulders. So all of those things we need to watch out for. Some things that can cast artifacts that can simulate pathology are things like heavy sheets and blankets and draw sheets and things like that underneath the patient. You need to try to smooth that out as best you can. So it really shows up most on asthenic patients where we have very high contrast. Even in the chest x-ray where we used high KVP, and a computer algorithm gives us low contrast. Because of the inherent high contrast within the patient, artifacts can show up where they would not otherwise. So what that might give us is what we refer to as a pseudopneumothorax. It's not truly a pneumothorax. It's just a skin fold or a sheet that's bunched up in such a way that it kind of looks like a pneumothorax. Okay, so make sure that the skin is not really all bunched up whenever you put the image receptor behind the patient. and make sure that the sheets and everything aren't bunched up above the patient's shoulders. You may wind up having to shoot a repeat because the radiologist looks at the image and says, what is this artifact? I can't rule out that this patient doesn't have some sort of pathology. So, especially on asthenic patients, if you have a hypersthenic patient, it's probably not going to be that big of a deal, or even a sthenic patient, but asthenic patients probably. So elevated shoulders, we just talked about that. So if the medial end is at T4 and there's no rotation, and the outer portion of the shoulders just look elevated, then that's exactly what you've got there. If you get that big V shape, then that's what you've got going on there. So kyphotic patients, again, sometimes give you that V appearance in the clavicles. So what you're going to do is look where the medial end is. And if it's at T4, then that's what you've got going on as opposed to kyphosis. We talked about that. So kyphosis, again, this assumes patients leaning into the image receptor, could be pathologic kyphosis. So we've talked about all that. So elevated shoulders. So looking at the two of these, we've got 1, 2, 3, 4. So this may be a little bit low. That's the end of the clavicle there. Might be a little bit low, but it's not dramatic. Over here we've got 1, 2, 3, 4, 5. So this is between 5 and 6 on this patient. That is truly, these elevated shoulders possibly, and over here we've got not just that potentially elevated shoulders, but also a kyphotic patient. Free intraperitoneal air is just kind of a bonus there. So just know the difference between those. Both can give you that V shape, but again, what you're going to look at is the medial end of the clavicle and make sure it's not in a bad place. Lordosis, again, is that if the clavicles are above T4, some references in the textbook said the manubrium, which you really don't see, but you see the ends of the clavicles, which articulate with the manubrium. If they appear flat and they're above T4 and there's less than 1 inch of apices above the clavicles, then the patient's leaning back, and that's what you're seeing here. So enlarge that so you can see a little bit better. It's open in my office, so I cannot enlarge that. Okay, but you can kind of see that, right? You got 1, 2, and then you've got these flat clavicles, and the apex of the lungs are covered up. You also kind of get that difference in appearance in the ribs. Ribs appear flatter. So the problem with both of them is they cause foreshortening of the lungs. Learn from what the mistakes you make and try not to repeat them. Before you make a repeat exposure, consider the history. What pathology specifically are we looking for? If this patient, what we're looking for is tuberculosis in the apex of the lungs, should we repeat this? Answer is probably yeah. For any other pathology in the apex of the lung, yeah, probably. For any other pathology anywhere else, yeah, probably not. Just do a better job next time. Okay? So anytime that you're going to have patients once in a while that are very difficult to image. And so if you ever have a question, just go to a higher authority. Explain the situation to the patient, to the doctor, or super user, the tech in charge, or whatever. And explain situations, explain the patient to them, and say, do we really need another one for this patient? We really need another repeat on this patient who has a pneumonia in the lower lobe of the right lung. And chances are they're going to say no. They can see what they need to see. Okay. So again, lordotic. Okay. So when we're talking about different positioning-wise, differences positioning-wise, what we're talking about is mispositioning of the mid-sagittal plane or the coronal plane. So we're going to talk about that in pretty much everything that we're
we're talking about, especially in the thoracic cavity and the abdominal cavity. So when we have mispositioning of one, what we want on a PA chest x-ray is the mid-coronal plane to be perpendicular, mid-sagittal plane to be perpendicular, mid-coronal plane to be parallel, right? All right, so in rotation, what we've got is our mid-sagittal plane is not perpendicular. It's some degree of an oblique, and it can be caused by turning of the head. So you get the patient up to the wall bucky. You say, I want you to put your chest up against the wall bucky. And maybe they're a small patient with a short neck, and they get up against it, and they can't get their chin up in that cup, and they turn their head just a little bit. If you remember back when we were talking about sternoclavicular joints, that was enough to determine, pathology, arthritis in a sternoclavicular joint. The patient would be elevated, and the side that they were looking towards would be elevated, and we could see the separation between the spine and the clavicle, right? So that's going to give us a little bit. But also the rotation that is caused by that is going to be pretty minimal, not enough for a repeat. And then also scoliosis is going to cause rotation. So we're going to look at the medial ends of the clavicles, look at rib elongation, look at the spinous process, make sure it's in the middle of the vertebra. So if we have a head turn, what we're going to see is slight separation. We get a slight amount of increase in the superimposition on one side and a slight amount of decrease on the other side. It looks like a pretty good chest x-ray though, right? If the patient doesn't have a long enough neck to get their head in that chin cup, you're probably just going to have to deal with this. The other alternative is to have the patient extend their chin far enough back that they might actually have the base of the skull over the upper portion of the C-spine, possibly over the apex as well. That slight amount of rotation is better than that alternative. Okay? So that's some rotation. Which way are we rotating? First off, what would you assume that this image is? It's chest x-ray, right? But is it PA, is it AP? AP portable.
Yeah.
Okay, I got one PA. Anybody say AP portable maybe? Yeah, most of your rotated chest x-rays are going to be portable. Just because it's going to be harder to get that perpendicularity, and it's going to be harder to get the patient straight in the bed. They're going to try to get themselves comfortable. So most of your rotated chest x-rays are going to be AP portable. So that would be my guess, plus with the telemetry leads. But what we've got then is we've got this clavicle, assuming that this is portable, we've got this clavicle over the spine and this clavicle out in the middle of the lung field. If you're just looking at this lower portion of the lung, it doesn't look all that bad, right? But if you look at the clavicles, you can see some distinct rotation. So clavicles, I have one uniclavicle. Let me just do this. All right, so I've got one big clavicle that sticks out like that. Spine's back here. As I rotate, all right, so they should be like they're superimposed. As I rotate, which way is my spine going if I rotate into a RPO? Which way is spine going?
Left.
Yeah, it's going towards the left, right? So which way is clavicle going?
Left.
Towards the right. So what's that going to do to the superimposition between the clavicle and the spine?
More right over the spine.
We're going to have more, right? So if your patient is rotated into more of an RPO, what you're going to have is more superimposition between the left clavicle and the spine and less between the right clavicle. All right, so the right clavicle is going to be off in the middle of nowhere. Left clavicle is going to have more superimposition. So what do we have there? Left clavicle has more superimposition. Right clavicle is out in the middle of nowhere. So providing that's an AP, that's what we've got going on. But what if our patient is PA? So let's go with the same thing. This was left clavicle before. If we go with PA
and I'm rotated towards into an RAO. Okay, which way does my spine go?
To the right.
To the right. Which way does my clavicle go? Towards the
Left.
left, right? Correct?
Yeah.
All right. All right. So which one's gonna have more superimposition, my left or my right? My right, exactly. Okay, so if you're shooting PA and you have rotation, then whichever side is closest to the image receptor is which way you were rotated towards, or whichever clavicle has more superimposition is which way you were rotated towards. On your APs, it's gonna be the other way around. Okay? So clavicle and rotation. So what we have going on with this one over here, it's a child. Yeah, it's a child. And it's a screaming child, moving child. Looks like we've got some quantum model. We've got some severe lordosis, and we've got some rotation as well. That's just a disaster, that x-ray. All right, so in your children, you're gonna get a better outcome shooting your children AP as opposed to PA. I know all of our literature says shoot PA 72 inches, but kids have pediatric children have a large heart anyway, and all your radiologists know it. And one of the most particular radiologists I ever worked with said that under the age of 7, it really doesn't matter if you shoot AP or PA, okay? So, put yourself into this guy's shoes. All right, that patient, how old do you suppose that patient is? 2, maybe? A little bitty one, right? So do you think that kid is gonna be more compliant if you put him in this dark room and you set him at the end of a table and you put this thing right in their face like this so they can't see anything, right? Or do you think that you're gonna get a more compliant patient if they can see everything that's going on? Probably AP. You're gonna get a better outcome with kids with patient AP. The problem with rotated child is that right up in here, and you really can't see it because, I mean, we've got so much stuff rotated over that direction, but right below the thyroid, you've got the thymus. The thymus is right in there, okay? And the thymus is basically what the children are going to base their immune system off of. And they've naturally got a large, dense thymus. So even if you were to get good density and contrast and not have this patient so terribly lordotic, with that amount of rotation, you're probably going to project your thymus into the lung field. Okay? Well, everybody should know that that's thymus, right? Well, they should, but what if your ER doc's not really thinking about it? You've got the thymus in the middle of the lung field, up in the apex. What else settles up there?
RSV. RSV.
RSV. Right. And now because, you know, you're locked into this mindset of shooting PA chest x-ray on a screaming kid who's rocking back and forth, you know, trying to get away from this thing in his face. You got a terribly lordotic chest x-ray, this rotated, that put the thymus in the lung field, and the ER doc admits the patient. He spends days in the hospital on antibiotic therapy to cure him of having a
Non-existent.
thymus. Yeah. So, very important, probably the hardest chest x-ray to get without any kind of rotation, probably the most important one. Okay, shoot at AP, you're gonna get a better result. Use pigostat if you have to. You're gonna get a better result than this in a pigostat. I've only ever seen one. He was strong, man. I only saw one kid almost come out of a pigostat. And he was rocking the whole thing. He was a beast. But every other kid's just sitting there screaming, you know, they can't do anything. But this kid wasn't having it. He was a hoss. So, rotated chest x-ray.
Alright, so, there are times we got a couple of things going on with this patient. One is that, obviously, we've got the clavicles way down here at the aortic arch. But also we've got this taken on expiration. There are times to take an expiration chest x-ray. There's two of them specifically. One is occasionally if a patient has a pneumothorax, if it's a small pneumothorax, they may ask you to shoot an inspiration and expiration chest x-ray. If it's 10% pneumothorax, you know, the lung markings are hard to see way up here in the apex of the lungs. And if the edge of the lung is right behind a rib, it's going to be difficult to see. So sometimes they'll ask you to shoot inspiration, expiration, chest x-ray to try to, on a small, you know, pneumothorax, try to get it off that rib. The other thing is if the patient has a foreign body. So the patient was eating a hot dog and somebody told a funny joke and they inhaled and they got choked and it went down which main stem? Right main stem bronchus, right. So what we might do is do an inspiration, expiration chest x-ray to see if that lung is getting any air to it at all. Diaphragmatic paralysis, you know, we may do a sniff test or something under fluoroscopy. But for inspiration, expiration chest x-rays, those are your two go-to answers on a test. Now, is that what we're looking for here? I don't know. The textbook just says it's expiration chest x-ray, which it looks like it is. We've got 1, 2, 3, 4, 5, 6, 7, 8 posterior ribs. Okay, so if that patient, you know, exhaled before you made your exposure, that's probably a good reason for a repeat. All right, so I think we've talked about most of these, so we're going to touch on them. Lung cancer, if you've not seen a lung cancer is subtle on a chest x-ray, unless it's a really big one. It kind of looks like somebody took a cotton ball and dipped it in barium and threw it at it'd be monitored now, but at the image. And so it leaves just this light area that doesn't really look like much, in all honesty. But it's a small localized area, are generally lung cancers. So, if they can see the lung cancer, if the patient's in bad shape, and they can see the lung cancer, and then, a little bit of positioning error is probably not going to be a big deal. So we do have something that looks kind of like a pneumothorax, but it's what we refer to as a bleb. And what a bleb is a hyperinflated alveolar sac. So it differs from, I think I did this last week. Hyperinflation of the lungs. Emphysema. There we go. Didn't we talk about that last week and I lost it last week too? Emphysema. It differs from emphysema in this. With emphysema, what you've got is constant irritation of the alveolar sacs, and they stay open at their normal widest level, okay? So it's kind of like the patient's in constant inhalation. What a bleb is where one alveolar sac just goes nuts, and it may be, this big. It may be massive, and it's going to have kind of scalloped edges to it, but you're going to have no lung markings behind that bleb, okay? So you might have a tendency to look at it and say, oh, wow, that's pneumothorax. No, pneumothorax follows the contour of the lung in the thoracic cavity, whereas a bleb can occur anywhere in the middle of the lung, okay? So it's a hyperinflated alveolar sac, and it does not look like a pneumothorax. It may just be that patient's anatomy, and they may not do anything about it at all. So we talked about maiden stem obstruction, respiratory effort, PE, or hemothorax, blood in the thoracic cavity, but outside of the lung, is just going to obscure the costophrenic angles, increase the patient density. You've seen a PE. Really on x-ray, you're not going to be able to distinguish between the two. If you ever hear hydrothorax, that's basically a PE. It's the same thing. It's just fluid where fluid need not be. We don't use hydrothorax all that much anymore, but you may hear it.
All right, so free air below the diaphragm. On chest x-ray, before we went to CR and then especially DR, it was a little bit difficult to see the free air below the diaphragm, so we would shoot our acute abdominal series, and we would say that the upright abdomen was to catch the free air, but it really didn't. The PA chest x-ray really showed it a little bit better. And you saw that in the earlier image. And hiatal hernia sometimes can be a incidental finding, and what you see with a hiatal hernia, especially intra-abdominal stomach, where the entire stomach is slid up above the diaphragm, is we shoot a PA chest x-ray on the patient and they have air fluid levels directly over their heart. It looks really freaky, but that's just the stomach and the air fluid levels in the stomach inside the thoracic cavity. So what they would have to do then is do probably a laparoscopic procedure, pull the stomach back down below the diaphragm, and do whatever they have to do to stitch the size difference up. So other things to consider, tube placement. If you're called on to do a portable chest x-ray on a patient, you've got tube placement. This is Swan-Ganz. Swan-Ganz goes all the way through the heart into the pulmonary artery. You notice we got a little bit of rotation there, but really all we're looking for in this case is the tip of that catheter. So is that rotation in any reasonable world a repeat? And the answer is no. You would not repeat that on your next image. You would try to do it without any kind of rotation. And then over here we've got a little bit of rotation as well. That's a chest tube here. And same thing, we wouldn't really repeat that because of that amount of rotation for chest tube placement. So central line placement, we've got a couple of things to consider on central line placement. One is, in the best case scenario, we want the central line to go down and stop somewhere around the right atrium, right? Sometimes if it's central line, it'll actually go upwards instead of downwards. And your doctor may decide to come back in and pull it, put the guide wire back in, pull it out, and try to get it to go in the proper direction. I have seen docs leave that central line, it's particularly the hard stick, and leave that central line going up instead of going down. Is that a problem? Is this something we ought to report to the Texas Medical Board, and go to war with a doctor over this? Is it bad that it's going up instead of down? It's ugly, right? But what vessel is that in? Is it in the subclavian artery? Or is it in a subclavian vein? It's a vein. It's a vein. So if it makes a left instead of a right and it's going up, it's probably going into the jugular vein, right? So which way is the blood going?
Up.
In the vein?
Down.
It's going down. It's going down. So if they're putting medicine into this and it's going up into the jugular vein, what's going to happen with the medicine? Is it going to go up into the brain and mess the patient up?
Mm-hmm.
It's going to wash straight back down, right? So most of your docs are going to probably readjust this to try to get it going in the proper direction. If it's a hard enough stick, I've seen docs say, it's good enough. I can dig around in there all day and nothing's going to change. That is not a problem whenever they do a jugular stick, but if they're doing a subclavian, sometimes it becomes a problem. Okay, so there's that. This needs to be a consideration too. Let's say you walk into the patient's room and you see a tray on the bedside table, blood all over it, guide wires, all the stuff, the needles, all the stuff that you would see if they put a central line into the patient. What's more important to see? Well, the first thing you should consider, is go ask the nurse, you know, are we doing this for central line? Nurse says yes. Ask second question, blood all over the table, blood all over the sheets, was it a hard stick? And if, you know, it's probably self-evident, it was a hard stick. Ask them, was it a hard stick? And if they say yes, third question, are we concerned about a pneumothorax? Because in light of what I just said, what's more important to visualize, the collapsed lung or the position of that catheter? Collapsed lung, right. So if you have to adjust your technique or your positioning or anything that you're doing in a case like that, then what you're going to be shooting for primarily is to visualize presence of pneumothorax. Secondarily would be placement of that catheter. Okay, so understand the environment when you walk in. You know, pacemaker. You have internal, external pacemakers. If a patient has an external pacemaker, make sure you don't pull a pacemaker lead. I saw that happen one time. I didn't see it actually happen, but I was working in a hospital where a technologist accidentally pulled, you know, in positioning for a chest X-ray, accidentally pulled a temporary pacemaker lead. The patient died, you know, so know your environment. All right, so I'd mentioned cancer is pretty subtle. Does that really stand out as something that's probably going to end this guy's life? Not really. The rest of the lung looks kind of cruddy too, but in the scope of things, it's not all that bad. Over here, that looks pretty nasty, right? So hopefully by the, you know, when they catch a cancer, it's not going to be quite that large. Okay. So pneumothorax, this is a quite large pneumothorax. Can you kind of make out the edge of the lung here?
Mm-hmm.
If you can't, what you can see is a total lack of lung markings out here as opposed to there. Largest pneumothorax I ever saw was a spontaneous pneumothorax, again, in a patient who had kind of a runner's build. Came in, obviously short of breath. We didn't know what happened to him, but we asked him, you know, what happened? He said, I coughed, and then I couldn't catch my breath. So we took an X-ray, and the entire lung was about that big right there. Beautiful set of ribs. Prettiest set of ribs I ever saw, because it had no lung markings whatsoever. So some of your spontaneous thoraces are going to be traumatic. Some of them are not going to be traumatic. And again, your demographic there is typically somebody with a runner's bill. Hyposthenic patients, especially males, have a tendency to get a spontaneous pneumothorax. So this is a fairly good sized pneumo here. They probably put a chest tube in for that. So bronchial obstruction, and I don't know the history on this one, but you can see that this diaphragm should be lower than that one because it's the left diaphragm, so it should be lower than that one. I don't know if that's a pathologic obstruction or if it doesn't really look like a foreign body. Could be, but it just doesn't look like one. Expiration, we talked about that. Pleural effusion. In order to visualize pleural effusion well, you might need to use a grid and you might need to increase your mass. Intraperitoneal air, we already looked at this one. Hiatal hernia, you see the airflow level directly over the heart.
Yeah.
So, all right, so what's our time? I didn't look at the time before I got started here. We're right at an hour. You know what, let's just take a look at some more x-rays and kind of assess them. Okay, so what do you see on this one? You see lines, yeah, so can you get those lines more out of the way than that on a portable x-ray? That looks like portable.
Bring them to the middle.
Just, yeah, reach up under the gown just a little bit and pull them straight down in front of the patient. Right? You can get those out of the way somewhat. Anything else?
What is,
A little bit of rotation. There's some rotation present, and the patient's leaning. Of those three, the patient leaning is less important. The leaning may be in part causing the rotation, though. Okay, so everything kind of works off of, everything else. So the leaning may be causing a little bit of the rotation. Patient may be kind of cocked up on one hip or the other. So if it's an AP, which way is the patient rotated? Right side down, left side down? 'Cause you're going to be asked on the test.
right side down?
Right side.
Right side down, yeah. Very good. Okay, so Moray artifact was really having a hard time with this, so we'll just kind of look at that one up there. What do you see in that one?
Cracked.
Again, lines all over the place, but what else do you have? What do you not see?
Bottom of the left.
The bottom of, or have really either lung. Looks like the patient's got a massive pleural effusion over here, possibly a pleural effusion over there, so may have bilateral pleural effusion. We don't really see a whole lot of rotation. Really not much, if any, at all. The clavicles are about where they need to be. So how could we identify if that was truly a pleural effusion, bilateral pleural effusion, or if, we got something else going on? What's your definitive exam for pleural effusion? I think you said it. Somebody said it. DQ. Yeah, DQ. So in that case, we definitely need a right lateral, possibly a left lateral. Patient's heart looks massive anyway, which very well could be causing the pleural effusion. So there may not be one over there. It just may be the patient's heart displacing all that lung. All right, so what all we got going on here? A lucky charm, right? So we got an artifact, badly kyphotic in both cases. Did get the artifact out of the way over there, but what else? You looking at it? All you got to do is say it.
Here's the right side.
What's that?
Where's the right side?
Well, where is the right side? That's a good question. Maybe another massive pleural effusion. Also, though, where is the left side? There's a lot of stuff the matter with this one. Patient's leaning, kyphotic, or lordotic rather. Got an artifact in this one. Probably a massive pleural effusion. You still see lung markings, so I wouldn't say that was a pneumectomy. They didn't remove the lung. It's just a massive pleural effusion. Probably needed to decube again. And then they didn't get the less unhealthy lung, the entire lung on the opposite image. Got a little bit of the same thing going on this one. Again, just cannot stress enough how important it is to angle your central ray perpendicular to the sternum. Perpendicular to sternum. Take a step back and take a look and make sure it's perpendicular to sternum. It'll eliminate all of your images that have this lordotic appearance. All right, so I don't know what the history on this patient was. I mean, it looks relatively healthy. The patient looks relatively healthy, not the x-ray. Maybe a little bit of scoliosis going on there, no real rotation. While I'm thinking about it, sometimes you'll see something on an x-ray that you think is scoliosis, not truly scoliosis. And what some people call it is compensatory scoliosis, some people call it dominant hand scoliosis. So, and it happens most of the time in people who who carry heavy things. So you got your farmers, you got your construction workers, things like that. So you have a tendency to carry heavy things on one side or the other, right? So what happens is that you get hypertrophy of the muscles on the opposite side of what you're carrying. All right, so if I carry in my left hand, I'm gonna have a tendency to lean towards my right. Overdevelop these as opposed to these muscles in my spine, and what the result would be is a bending of the upper portion of the thoracic vertebra towards it, away from the dominant hand, I'm sorry. So I carry in my left-hand side, I go towards my right. Okay, that's not truly scoliosis, that's just, you know, again, they call it compensatory scoliosis. It's not really scoliosis, it's just that the muscles on that side have overdeveloped and caused that. A lot wrong with that one. We're, again, we've got some sick people in this one. We've got a lot of things going on though. We've got what looks like they might have just had, you know, some sort of, no, I was gonna say some sort of open heart surgery, but I don't see any kind of zipper. Looks like we've got some sort of chest tube going on. Rotation doesn't look bad, but we don't have the bottom of the lungs. So the other thing with having the clavicles, you know, the shoulders up, you got that V-shaped clavicle, is that that's the result in a lot of cases. Because the shoulders are up, then you put the top of the image receptor 1.5 to 2 inches above the outer portion of the shoulder, and what you wind up with is missing the bottom of the lung. So it's important, even if the patient can't sit up, and you have to shoot them supine, kind of get a good idea where the shoulders should be, or where they would be if the patient was upright, okay? And position accordingly, otherwise you're gonna miss the costophrenic angles in a lot of cases. A little bit of rotation, nothing real bad. Pacemaker lines and telemetry all over the place. Some pretty significant rotation there. Again, what's going on with the patient? So we've got a couple of things really with this one. We've got a poor inspiration effort. We've got a patient who's probably on a vent, it looks like. They've had open heart surgery at some point. They got a chest tube in over here. And that central line there. So we've got a lot of stuff to consider. Are we just looking for the central line placement? If the answer is yes, is that a repeat? Well, we can see the position of the central lines, probably not. It'd be kind of embarrassing to turn that in. We got rotation. So does central line placement, does a rotation affect central line placement? No, not really. Does the chest tube, if this is for chest tube placement, and chest tube placement in a lot of cases is to see if the lung is reinflated on the side where the chest tube, you know, where they place the chest tube. So is this lung up? Is it reinflated? Answer is yeah. Or sometimes it may be follow-up from pleural effusion. Does it look like pleural effusion is drained if that's what it was for? Answer is yes. So all of those things individually are, you know, I mean, it's okay chest x-ray to diagnose each one of those things. But if it's for something else, do we need a better inspiration? And the answer is yeah. All right, so again, what is it we're doing the exam for? Find that out, and that may drive whether or not you go back and reshoot this. But this one has 1, 2, 3, 4, 5, 6, 7, 8, 9 posterior ribs. That's actually more than what I thought it was going to have. So the inspiration effort is not as bad as what I thought it was. What about this one?
Cut off at the bottom.
Yeah. Again, probably put the top of the image receptor above the, you know, the elevated shoulders, probably AP supine. Yeah, that should be a repeat, in my opinion. Oops. A little bit of rotation. I wish I had the history on this patient. That is a sick looking patient. Massive pneumothorax here. So you probably gonna be seeing this patient again post, chest tube insertion. Kyphotic, chin's in the way, a lot of things wrong with this. Clipped on the right-hand side. So we got a lot of stuff going on with this one. The chin needs to be elevated. We need the angle perpendicular to sternum. Make sure that we include that right lung. How about that?
Too much.
Collimation, that's just awful. And that's a kid too, you know? Unless we're looking for some sort of, foreign body, in which case we should be shooting pretty much from the nose all the way to the rectum in one image if we can get it. I think though, I have to read back through this, but I think what we're looking at over here is this, what looks like a cyst. Solitary expansive lucent bone lesion mid-shaft to the right. It's a femur. Femur? Really? This guy went to 12 years of school and can't distinguish femur from a humerus. But anyway, it's probably a bone cyst. Bone cysts are very common in long bones in kids and young adults. All right? And in a lot of cases, people don't know that they've got a bone cyst until they have a pathologic fracture. It's a cyst. And what they'll do is they'll go in there and they'll clean out that cystic material, and then they'll take some bone chips from somewhere else in the patient's body and put it in there and hope that it takes and makes a solid bone. Femur. Okay.
So,
All right, anybody seen this?
yes.
Trauma situation. Yeah. Did you touch the patient?
No.
You should have. Put on some gloves and touch the patient. This is what we refer to as subcutaneous emphysema. All right, so you see this in, it can happen with any kind of a pneumothorax, but you see it most of the time with broken ribs. In a trauma situation, what you get then is the air comes out of the lung, out of the thoracic cavity, and into the muscles in the in the chest. So it's subcutaneous emphysema. I can come up with emphysema on subcutaneous emphysema, can't do it for the lungs. All right, so subcutaneous emphysema is just extravasation, essentially, of air into the muscles in the thoracic cavity. And you can tell that the patient has subcutaneous emphysema just by touching them. And, when you get a mylar balloon and it starts to deflate and then you touch it and it kind of crackles, it's that. They call that crepitus. All right. So crepitus just means kind of like grinding, and that's what that feels like. If you just push just a little bit, it'll be kind of soft, and it goes. It's no, not doing it. Crepitus is a good name for it because it's kind of creepy.
It's crazy.
All right. So massive pleural effusion or pneumectomy, one of the two. Leaning and some pretty severe rotation. I would absolutely repeat that just because I would be embarrassed to not. Some pathologies you'll see just kind of jump out at you. I did kind of read through this a little bit, and it was kind of non-specific as to what the radiologist thought that was. Just a big calcified oval, I think is what it said. Massive pleural effusion, again, on that one. And that's kind of what you're going to see in a lot of cases with a patient who's had a pneumectomy, is that you might see a little bit of air, post-op, a little bit of air, and then what looks like massive pleural effusion. So what I'm going to pull up there,